Good morning to everybody. As president of the International Colorectal Cancer Club, it's my pleasure to welcome you to our first Zoom meeting of 2025. The topic is rectal prolapse, search of reference points of space and time. I think we have a very interesting international program with speakers around the world. And it's my pleasure to first introduce Dr. Patanka from Mumbai, who will share the Indian experience of treatment of rectal prolapse with us. Please go ahead.
Thank you, Professor Marco. It's a proud privilege for me to share our work with you. Can you see my slides and hear me clearly, Professor Marco?
Yes.
Perfect, yes.
Great. So I hope in the next 20 odd minutes to tell you a little bit about some of our experiences in the management of rectal prolapse in the Indian subcontinent. So a lot of thinking has gone into this tri-compartmental prolapses. I work in Mumbai in Zen Hospital, which is a very famous pelvic floor center. We do a lot of prolapse, a lot of incontinence surgeries, obstructive defecation, and multi-compartment prolapse. So I think it's important to understand that any treatment that you advise for rectal prolapse needs an evaluation of all the three compartments before you can narrow down on what is important. And the key issue is these hypogastric plexus that must be preserved, because it is not simply an anatomic correction, it's also a functional correction. In the words of William Allingham, he said, numerous operative procedures have been recommended as a cure for this malady, but I cannot say I am satisfied with any single one of them. I have seen all of them fail. circa 2025, 150 years later, pretty much the same thing can be said about all operative procedures for rectal prolapse. So rectal prolapses comes in all sizes and shapes, and today we are only going to discuss full thickness rectal prolapse. The one thing that is common in all of them is an abnormally deep pouch of Douglas, and as I keep telling my fellows, part of this operation must be a Douglasectomy. You make a deep pouch of Douglas into a shallow one, must address the lax muscles of the pelvic floor, a weakness of the sphincters, and a lack of normal fixation of the rectum with mobile mesorectum. Two basic theories of the etiopathophysiciology. One is the Moskowitz theory that it is a sliding hernia of the anterior wall of the rectum, and the Broden-Snellman's theory of the intussusception of the rectal wall. In our center, we routinely do a colonoscopy, a MR diffigography, and selectively also do an anorectal manometry using a 16-channel water perfused machine in all patients who have incontinence or obstructive defecation syndrome. The basic aims of treatment are number one, to anatomically correct the prolapse, number two, to prevent recurrence, but very importantly, to maintain or improve the functional outcomes of defecation. That is, correct the incontinence if it's there and prevent a de novo constipation from happening. There are indeed many ways to skin a cat. In the words of Charles Wells in 1959, he said, I have traced in literature between 30 and 50 operations for prolapse and would like to add still one more. As of 2025, there are 106 procedures described for rectal prolapse, and I'll try and take you through a little bit of history on all of them. There is, if you look back at literature, there is a lack of high quality evidence, often no standardization and follow-up, and we really need much more trials before we can actually say the final word. This is what is called the Dunning-Kruger effect. I think the early part of your career, you learn some operations and you think you mastered it all. Then you have patients who get de novo constipation or nervy erythematous problems, and you realize that functional bowel surgery, to me, can be more challenging than malignancy. In a cancer rectum, a patient is often okay to have a bit of LAR syndrome. He doesn't want recurrence. He or she doesn't want the tumor to come back. In a prolapse, not only the anatomical correction must be good, but the functional outcome must be excellent. So these are the various things that I'm going to talk about. The first one is the age-old Delorme's, which has a reasonably acceptable recurrence rate of between 6 and 30%. Reasonable correction of continence. My own favorite among the perineal operation is the Altomeyer's operation, which I do quite regularly for all our full thickness prolapses who are elderly and not fit for general anesthesia. And these are some of the results that you can achieve in these elderly patients. The recurrence rates also are around 10%, and correction of continence and constipation is very good, except that both in Delorme's and Altomeyer's, the recurrence rates are higher than all abdominal procedures. We have been doing something called a stapled Altomeyer's, which I will show you in this video that I was done, and we've published this in the Indian Journal of Surgery, making this really very simple, where we use two linear cutters to divide the rectum, and then you can either use a contour or another linear cutter and then suture it back, as you can see me doing here. So two linear cutters at 12 o'clock and 6 o'clock position, and then either a TransStar or a contour stapler or even a linear cutter to dissect this. Again, at a 5-year follow-up, we found a 11% recurrence rate, 40 stapled Altomeyers so far. Another kid on the block is to do the STAR operation. As you know, Dr. Antonio Longo had proposed this for obstructive defecation, but smaller fill thickness prolapses in male patients who have unicompartmental prolapse. Another option is to use the STAR procedure if your prolapse is less than 5 centimeters in size. But generally, ladies and gentlemen, all the perineal operations, though they have a low morbidity, have a recurrence rate between 10 and 20%. We then come to the abdominal procedures, which are lap, open, and now robotic. We do all three of them. But the primary thing here is to mobilize the rectum. What John Gallagher did and published in British Journal of Surgery was simply dissect the rectum all around and keep the patient in the head down position for 7 days, and he had a 18 to 20% recurrence. Mind you, no mesh, no sutures, no pulling up, just circumferential dissection of the rectum. This is a paper in DCR in 2005 looking at recurrences over a 5 to 10 year period showing that. The evolution in this was, along with the posterior dissection, Wells described the use of posterior mesh rectopexy via the Evalon sponge, which quickly went out of fashion because of the foreign body reaction, the collections and infections, and the pelvic abscesses seen in a proportion of patients. The pelvic posterior mesh rectopexy has now gone out of fashion, replaced by the suture rectopexy, because the basic problem with all posterior operations is that constipation is often worsened, and in about 20% of patients, you will have de novo constipation appearing after posterior dissection of the rectum. The recurrence rates are very acceptable. The continence is often improved in any form of rectopexy done abdominally. But we then come to what is called the Friedman-Goldberg's operation, which is a very common operation among the American colorectal surgeons, and very good for patients who are ASA1, ASA2, and who have constipation along with prolapse. What we do here is resect the redundant rectosigmoid and then do a posterior sutured rectopexy in addition to resecting the redundant loop of sigmoid. This is an excellent operation if the patient has a full thickness rectal prolapse with preoperative constipation. The problem is the morbidity, the anastomotic leak, which can be a significant problem in patients who do develop that. The suture rectopexy was first talked about by Catate, which means a full mobilization of the rectum circumferentially and fixing the rectum with the posterior sutures. If you look at this data, the recurrence after posterior suture rectopexy is almost the same as if you're using a mesh. So over the years, I think the mesh rectopexy, at least in this part of the world, has almost stopped, and everyone is now moving to a posterior suture rectopexy. That is the group of surgeons who like posterior mobilization of rectum. In our hospital, I think 90% are ventral mesh rectopexies, but I'll tell you a little bit about our experience as we go on. But as they say in life, every problem has a solution, and every solution, unfortunately, has a problem too. So clearly, the problem, why do we get constipation after posterior dissection of the rectum? It is basically because of the autonomic nerve injury resulting in dysmotility and impaired evacuation. So not only patients who have pre-op constipation may get worse, about 20% of patients after posterior dissection will get de novo constipation developing here. The division of the lateral ligaments also is an important rule, and I was fortunate to actually learn about this both from Dr. Duhur and from St. Mark's Hospital in London, where I learned this. So we need to evaluate all the three compartments thoroughly. I tell my fellows and residents, you need to see these patients in left lateral, lithotomy, as well as in squatting position. It is important to evaluate the anterior, middle, and posterior compartment. And in our own series of almost 200 patients now, we find almost 30% have multi-compartment prolapse. If you only stick a mesh or suture it posteriorly, you will often land up with a patient who has dyspareunia, SUI, or a vault prolapse, which gets worse with time. So you read all the three compartments before planning what it is. Dr. Duhur published this in British Journal of Surgery in 2004, and the concept was the ampulla of the rectum should not be denervated and the lateral ligaments should not be divided. It has really been our go-to operation in our center. We do a lot of patients who have multi-compartment prolapse, who have obstructive defecation. In India, we have patients who have multiple deliveries. Our patients tend to be much younger than our European colleagues see. And I think our average age of surgery here is about 44 years, as opposed to in the 6th and 7th decade that my mentor in this operation was Dr. Roland Scherer, who I learned this operation from in the hospital Walter Frieda in Berlin. And in his center, when I was there for a month, way back, I found that most patients are in the 60s and 70s. On the other hand, in India, with multiparous patients, patients having poorly managed labor, home deliveries, the incidence of pelvic floor problems in our country is much more than what you see in Europe. These are often productive ages of life and much younger patients than you see in the Western counterparts. I think what we pay attention to is complete division of the rectovaginal septum. I usually do this operation only using a monopolar hook. Generally, no energy is required for this. Though we have all the thunderbeats and harmonics and ligatures, I find using a monopolar hook the best technique. I think most of the dissection is being done by my left hand, and the failure of this operation is inadequate dissection of the rectovaginal septum. So we'll go down to the endopelvic fascia on both sides without opening it, divide the rectovaginal septum completely. Most cases, I will have an assistant putting a finger in the vagina, lifting it anteriorly, and overdo the dissection till you go to the pelvic floor completely before you put in a mesh. Now, the choice of mesh for a younger patient is a biological mesh if they are sexually active. In elderly patients, I tend to use a macroporous polypropylene mesh. The shape of the mesh is decided by what the underlying problem is. In a full thickness rectal prolapse without ODS or other compartment prolapse, I would use a straight macroporous lightweight mesh. In a patient who has a pelvic floor problem, I tend to put a L-shaped mesh, one limb of the L on the left levator ani, the extreme end of the right levator ani, and the proximal part onto the sacral promontory. A patient who has a concomitant vault prolapse, I use two strips of mesh, I suture the stem back together and create a Y. One limb of the Y goes to the posterior aspect of the vagina, one limb of the Y goes to the anterior part of the rectum, and the proximal part gets sutured or tacked onto the promontory before we actually extraperitonealize this. We were initially, as you can see in this video, using article where they say that use of PDS will actually decrease the chance of having mesh erosions and mesh infection. And the last part, obviously, is to use this to extraperitonealize the mesh. We also do with a 5-year follow-up in the Journal of Minimal Access Surgery in 2021. I think from our department, we have a publication of biofeedback, one publication on our technique of MR diffugography, and we have now done more than 3,000 MR diffugographies in our department. The key issue here is not only do patients not get de novo constipation, there is an improvement in constipation in more than 24% of patients who have this. What mesh to use? Obviously, the biological mesh has a cost. So we use it a biological mesh only in young patients who are sexually active. We have moved away from using Ethibond and shifted completely to using PDS. The concern really is dyspareunia and mesh infection. And we had one patient come to us in our series about 6 years ago with a piece of polypropylene mesh in a posterior rectopexy, which came out through the vagina. So patient had a leukorrhea, discharge, pelvic inflammation. As happens, a piece of mesh eroded through the posterior fornix, and we were able to take it out under a short anesthesia. A recent publication in DCR looking at ventral rectopexy using a biological graft, and this is a 15-year retrospective cohort study showing that biological grafts for ventral mesh rectopexies are safe and probably as good as using a macroporous polypropylene mesh. So, ladies and gentlemen, I'm going to show you a paper hot off the press. This is still an e-publication looking at a consensus, and this was a consensus taken from a panel of experts, and these are the experts that were actually there. Many domains were identified, but to put it in short, this is a publication from February of 2025 from DCR looking at a consensus on VMR, and it said VR is indicated for patients with full thickness rectal prolapse and selected patients of high grade interception. Very suitable when findings of multi-compartment prolapse. Biological grafts may also be used. The utilization of a lightweight macroporous polypropylene mesh, like I showed you, seems to be the most favorable one. The recurrence rates are very low. They have shown a high recurrence rate using collagen graft, but the newer biological graft, as I showed you from this paper, is very good. It is important to look at these patients holistically to evaluate all the three compartments. We always see these patients along with our urogynecologist colleague, and this can be a good option for surgical repair if the anatomical thing. To summarize, ladies and gentlemen, you can see that the resection rectopexy is a very popular operation in the United States. I believe that the ventral rectopexy is more popular in Europe. I think Prof. Marco Conman can tell me about this better. But the resection rectopexy remains an excellent operation with the low recurrence rate, though it does have a morbidity of anastomotic leak and strictures. The mesh posterior rectopexy is now completely getting replaced by the posterior sutured rectopexy. And we must increasingly look at data on the ventral rectopexy where the posterior dissection of the rectum is not done. However, it has the problem that it has a mesh. Where are we going? We are getting 3D bioprinted degradable meshes, which are of a material similar to Vicryl. These are impregnated with the patient's stem cells, and maybe in the years to come, these stem cells will regenerate type 2 collagen to strengthen the pelvic floor. There is an interesting paper looking at MRI biomarkers, looking at the muscle composition. All of you know about type 1 and type 2 collagen. This biomarker is actually looking at the muscle composition, predict about which patients do not do well after routine surgery. Maybe in the years to come, we'll be tailoring our operation based on the biomarker function. And finally, there is development of a 3D printed biodegradable mesh with antimicrobial property. This is a publication from December of last year. And maybe we will not be using polypropylene meshes in the years to come. I think data still has to come. So in summary, ladies and gentlemen, it is important to tailor the procedure to the patient's condition, to the anesthesia fitness and the risks. We need to discuss about the patients with the risks and recurrences. In our center, perineal operations are done for elderly patients who are not fit for a general anesthetic. In all patients fit for anesthesia, we will do a laparoscopic or robotic ventral mesh rectopexy or a resection rectopexy. We hardly do any posterior mesh or suture rectopexy in our country, but it's important that we need to evaluate all the three compartments, look at the patient holistically before advising the appropriate surgery. Thank you very much for your kind attention.
Yeah, thank you very much for your presentation and your point of view. Are there any questions from the audience, listeners? If
Can
not,
I have a question?
may I start? You said you use resorbable mesh for young patients. My impression is when you look at these patients, they have a low tendency of, to develop adhesions, to develop fibrosis. I mean, that is the basic or one of the basic problems probably of this disease, of the dissensus. So do you see these patients return after 10 or 15 years with a recurrence if you use a resorbable mesh? Because we basically also I use non-resorbable or partially resorbable meshes also in young patients, but I prefer the dorsal position of the mesh, not in between the vagina and the rectum wall. So what is your experience?
So we have been doing now biological meshes for 7 years, and our recurrence rates are between 2 and 3%, which are almost the same as using a macroporous lightweight polypropylene mesh. I showed you in my presentation a 15-year study looking at biologic grafts showing about the same recurrence as a polypropylene mesh. But we've just done one patient using a delayed absorbable phasics mesh, which has a year and a half to resolve. And maybe that would be the answer to your question. Time will tell.
More questions?
Can I have a question?
Yeah, Artem, please go ahead.
Thank you for your brilliant presentation, Dr. Roy Patankas. Tell me, please, what is your preferred method of surgical correction of the rectal prolapse in male patient?
So in male patients, we always talk to them about the possibility of injury to the nerves. We need to do an informed consent of them. If the patient does not consent for that, then if the prolapse is less than 5 centimeters, I do a perennial stapled Altomeyer's. If they are larger than 5 centimeters, in our department, our procedure of choice is a Altomeyer's operation. Patients who consent for the risk of nervi regentis injuries, I will still do a ventral mesh rectopexy, and we are able to see the nerves beautifully. And we have not seen the problem with sexual problems after this surgery, though we do consent our patients for this. But your point is well made that you need to be careful in young adult males.
Thank you.
Hi,
Professor
Dr. Roy.
please, your question.
Yeah. Dr. Varut from Thailand. Thank you, Professor Roy, for your excellent talk and extensive experience you share with us. My question is probably similar to Dr. Arten because I think the rectal prolapse in young male is different from the multipallas lady. In terms of pathophysiology, what do you think is the root cause of the rectal prolapse in young male? Thank you.
So I still think it is a failure of the pelvic floor, internal rectal prolapse proceeding to a full thickness prolapse. I'm still a believer in the theory of the internal rectal prolapse proceeding to external rectal prolapse. If you look at the pelvic floor functioning of these patients, when you do a MR diffeography or manometry, you'll often see this compounded by the patient's problems.
Thank you.
Okay, thank you very much. So I think if there are not more questions, I will hand over to Andrei Ivanov, who is going to introduce the next speaker.
Next speaker from China, from city of Guangzhou, Professor Donglin Kren. He is head of center for this problem and actually to connecting traditional China medicine and European medicine. It's very interesting. Please go ahead.
Everyone can see the PowerPoint. It is okay?
Yes.
Perfect.
Okay, thank you. Thank you. Dear experts and professors, I am Dr. Di Zhang from the 6th Affiliated Hospital of Sun Yat-sen University. Professor Donglin Ren is my teacher, and today I am very honored to share with you Professor Donglin Ren's personal experience in the treatment of rectal prolapse. And let's start with some background information on rectal prolapse. The incidence of rectal prolapse in the general population is about 0.5%. It is 6 times more common in females than in males, and the peak incidence occurs around the age of 70 years. And 50 to 75% of patients with rectal prolapse also suffer from fecal incontinence, while 25% to 50% experience constipation. Rectal prolapse often does not occur in isolation, but frequently associated with other pelvic floor disorders, such as uterine or vaginal prolapse. And also, chronic and recurrent rectal prolapse can lead to chronic ulcers and necrosis of the rectal mucosa. The patient, this patient, we can see the picture. The patient we're discussing has long-standing prolapse resulting in necrosis of the rectal mucosa. Professor Donglin Ren has treated over 500 cases of rectal prolapse. In our clinical practice, we often encounter various types of prolapse, and the prolapsed rectum can have different shapes. We can see these pictures. And in conclusion, the cone-shaped, globular-shaped, columnar-shaped, or arc-shaped, and these different shapes reflect the potential underlying anatomical defects in rectal prolapse in different patients. And we also know that the exact etiology of rectal prolapse remains unclear. However, we have a better understanding of the anatomical defects associated with it. For example, weakness or damage to the pelvic floor muscles and the muscles surrounding the anus and the rectum often lead to rectal prolapse, like this. And we can see the MRI can reveal changes in the morphology of the pelvic floor muscles and the external anal sphincter. In patients with rectal prolapse, the external anal sphincter complex is thin and has sparse muscle components. And we also see that this is the levator A muscle. The levator A muscle is also markedly weakened. And on the right, we can on the right picture, we can see that this is a normal appearance of the levator A muscle in a volunteer. And on the left picture, you can see the weakened levator A muscle in a patient with rectal prolapse clearly separated from the rectum. And this diagram illustrates the crucial role of the levator A muscle in supporting the rectum. Weakness and atrophy of the levator A muscle are the most common anatomical defects in rectal prolapse. And I think this is the key of the anatomical defect in rectal prolapse. And another anatomical defect in rectal prolapse is a deep Douglas pouch. A deep Douglas pouch indicates a deficiency in pelvic floor tissue. And we can see that from this picture, there is almost no tissue support between the end of the rectal mesentery and the sphincter. And this is a photo from an open surgery for rectal prolapse, showing the deep position of the Douglas pouch, which allows greater mobility of the rectum. And this is also evident. We can see that the evidence in this photo from an Otmere surgery, where the deep position of the Douglas pouch is clearly visible. And this is another anatomical defect, is redundant sigmoid colon, which increases the mobility of the rectum. And another defect is anal sphincter weakness and laxity. And this is a common appearance of the anal sphincter in patients with rectal prolapse. You can clearly see that the anus is markedly dilated and appears as a funnel in its natural state. And another defect is separation of the rectum from the sacrum. On the right picture, you can see a normal distance between the rectum and the sacrum. On the left two pictures, the MRI of the patients with rectal prolapse show a significantly increased space between the rectal wall and the sacrum. and indicating a lack of fixation of the rectum to the sacrum. And some cases of rectal prolapse originated from internal rectal intersection. This is a very rare case where a rectal tumor caused internal rectal intersection, leading to rectal prolapse. And let's talk about the treatment options for rectal prolapse. Conservative treatment mainly targets symptoms related to rectal prolapse, such as fecal incontinence, pain, and constipation, which can be alleviated with medication. However, non-surgical therapies cannot correct the prolapse itself. Let's briefly review the different surgical options. For rectal prolapse with a length less than 5 centimeters, the TST-36 large diameter circular stapler is an excellent choice. You can clearly see the fat tissue outside the rectal wall in the resected specimen, indicating that this stapler can resect the entire layer of the prolapsed rectum. And this is DeLong procedure. The indications is that prolapse less than 5 centimeters or limited to 1 quadrant, and the recurrence rate is about 16 to 30%. And improvement in fecal incontinence is 40 to 50%. And the DeLong procedure can correct prolapse, but does not address the anatomical defects we mentioned above, since it only resects the mucosa of the prolapsed. We can see that it only resects the mucosa of the prolapsed rectum and plicates the muscular layer of the rectal wall. The recurrence rate is relatively high. And this is Altmaier procedure. The recurrence rate is about 7 to 20% and the complications 10%. And this surgery can correct prolapse. Let's see a video.
The Altmaier procedure is suitable for patients as follows. A brief introduction of history. The patient is in a lithotomy position of higher buttock and lower head. This position can prevent the abdominal contents from falling into the pelvic cavity and can obtain a good exposure. Incision was made into the outer rectal wall 1.5 cm above the dentate line, and application of the ultrasonic scalpel can reduce hemorrhage. Then the surgical field can maintain clear. Make an interrupted suture to close the pelvic cavity. Incise the inner rectal wall and suture it to the outer inside wall by full thickness, and move on and on. Until a circumferential resection of the prolapsed intestine was completed. To avoid injuring the internal sphincter, do not go in too deep when cut off the posterior intestine wall. Ensure a complete hemostasis. The mesorectum vessels must be ligated firmly, especially the big ones. Coarctation of the levator fissure and partial plication of the sphincter is meaningful to strengthening the posterior pelvic floor and preventing the recurrence of the prolapse. Injuries of the posterior wall of the vagina should be avoided carefully in female patients during the procedure. This patient can maintain a normal bowel movement and continence. No sign of anal stenosis. No recurrence of rectal prolapse during the 7 months follow-up after the procedure.
So from the video, we can see that this surgery can correct prolapse, elevate the Douglas pouch, and strengthen the levator ani muscle. The advantages of Otmir procedure is that not only resect the prolapse bowel, the rectum, but also repairs and repositions the levator ani muscle defects, which can be done both anteriorly and posteriorly. And this is Goldenberg procedure, the sigmoid ectomy with rectopexy. And the recurrence rate is about 2 to 5%, and severe complications about 2 to 20%. And this procedure is suitable for patients with constipation, but not for those with fecal incontinence. And it removes a redundant sigmoid colon without the need for mesh, making it relatively easy to perform. And this is a Ripstein procedure. We can see that it will free and fix the rectum, use a mesh, and the recurrence rate is about 2 to 5%, and complications about 20%. and fecal incontinence about 20 to 60%. And the main disadvantage is use the mesh to secure the rectum, leading to complications related to foreign body reactions. And this is the most popular operations for rectal prolapse right now. The laparoscopy, ventral mesh, rectal pexy. And we also about the LVMR, and the 10-year recurrence rate is about 3.4 to 8.2%. And the mesh-related complications is about 4.6%. And improvement in constipation is about 23%, and improvement in fecal incontinence 90%. And this surgery only mobilizes the anterior rectal wall. We also know that the synthetic mesh is commonly used in LVMR, which carries the risk of erosion into the rectal wall. And during the LVR procedure, we can see many important anatomical landmarks, including the position of the Douglas pouch. We usually open the peritoneum at the lowest point of the peritoneal reflection, and the sacral promontory is a key location for mesh fixation. We often use biological mesh for LVMR surgery, and this diagram illustrates the suspension of the rectum in LVR surgery. The mesh can be fixed to the sacral promontory. We often use the tacks to fix the mesh. Finally, the pelvic peritoneum is sutured closed to elevate the Douglas pouch. And compared with open rectal suspension, LVMI surgery has significant advantages. It has less blood loss, faster functional recovery, and shorter hospital stays. And we also know that the traditional view is that elder patients are more suitable for perineal surgery. However, recent studies show that the complications rate for perineal surgery is about 1.3%, while for abdominal surgery, it is 1.35%. Both laparoscopy and perineal surgeries are safe for elder patients. And robotic surgery for LVMI has similar outcomes to laparoscopy surgery. The advantages of robotic surgery include easier suturing and fixation, but the disadvantages are longer operation time and higher costs. So let's make a conclusion of the status and issues in the treatment of rectal prolapse. Lack of high-level evidence in the literature. Treatment choices are mostly dependent on the experience of physician or a single center. Classification provides little guidance for clinical care. No international standards. Lack of uniformity in treatment and difficulty in managing commodities. So we must understand the treatment goals of rectal prolapse. Treatment of prolapse, correcting anatomical defects, treating constipation or incontinence, avoid creating new problems. So our experience in treating rectal prolapse is that the choice of surgery should be based on the specific circumstances of each patient rather than the surgeon's preference. So we should do the surgery based on the anatomical defects in every patient. For example, anal sphincter laxity often persists in patients with rectal prolapse, even after resection or suspension after the prolapsed rectum. For such a patient, we often recommend additional procedures like anal encirclement or post-operative biofeedback therapy. This is encirclement of anus. So in this patient, we performed an LVMR surgery combined with an anal encirclement, resulting in a near normal anal appearance rather than a funnel. Some patients also have very thin and weak anal sphincter muscles. For these patients, we can perform unilateral or bilateral external anal sphincter plication after rectal prolapse surgeries. For this patient with severe levator anal muscle weakness, just like this, we can also perform levator anal muscle reconstruction or plication after the prolapse surgery. And if necessary, we will use biological mesh to help us to enhance the levator anal tensions. So the treatment of rectal prolapse remains a very significant challenge. Successful treatment is not just about performing a single surgical procedure. The longer the follow-up time, the higher the recurrence rate. So currently, there is no surgery methods. A single surgery method for rectal prolapse has a particular high success rate. The treatment of rectal prolapse often involves resection, suspension, fixation, preservation, reinforcement, and support. So I think in the future, combining multiple methods tailored to specific anatomic defects may effectively reduce the recurrence rate of rectal prolapse. Combined multiple procedures may be better than a single one. And thank you. Thank you very much.
Professor Ren, thank you very much for your excellent presentation. Are there any questions or comments?
May I ask question? Do you have any national guide for preoperative examination? I mean, actually, physiological test before operation or adding MRI or something like this?
Thank you. Excellent questions. In our clinical practice, every patient in our must do the MRI defecation. We use the MRI defecation to evaluate the anatomical defects of each patient, including the young males and the elder women. Just like the last speaker, two experts have just asked the questions about the surgery on young males. We do the surgery options just based on the particular anatomical defects of each patient, but not just based on the age, just based on the sex. We do the surgery based on the MRI results.
Thank you.
Okay, we go. Varut has a question. Please go ahead.
Yes. Thank you once again for your excellent talk and very nice philosophy. I particularly like the idea of the combined approach, particularly for the perineal approach that you add levatoplasty. I think it's a very good idea. The question I would like to ask you about is about learning curve, because you have extensive experience, probably all the approach. Can you discuss about learning curve for such procedures? Because many of the audience are beginner. Which one they should go for? Better we go for advanced surgery or try the one that is simple but low success rate? What is the learning curve about that? Thank you.
Thank you. Excellent questions. For some simple patients, just about not about the recurrent rectal prolapse. We all know that the recurrent rectal prolapse is much difficult. It's much difficult than the simple rectal prolapse. We think that the LVMI is sometimes need a very good team to help to experience the learning curve, because one operation cannot do without the assistant. So we think that about 10 to 30 operations can make a very experienced operation experience the learning curve. But for Otmir and Dulom, I think that the learning curve is just shorter. It's about shorter. But if the operation about the pelvic reconstruction sometimes is very difficult, because many abdominal surgeons do not have the anatomical knowledge about the pelvic muscles. So we think that it better have some knowledges, or have learning some knowledges about the pelvic anatomic structures. So if he do not have the pelvic anatomic knowledge, he cannot do a very good surgery. So I think the learning curve about the pelvic reconstruction is much longer. It's much longer. That's my answer. Thank you.
Thank you.
May I?
Oh, thank you.
Prof, may I ask a question?
Okay.
Prof, how would you manage a patient who has a concomitant vault prolapse or a tri-compartmental pelvic organ prolapse? What is your approach?
Sorry, I can't hear your question. Can you pardon? Thank you.
Yes. What would be your approach if the patient has a tri-compartmental pelvic organ prolapse? If all the three compartments are coming down?
We may choose the laparoscopy, the LVMR. This is our first choice.
Okay.
Thank you.
Thank you.
May I ask a last question? You showed us the young 14-year-old patient where you did the perineal resection. Usually, physicians argue that you do the perineal approach in patients that are unfit for abdominal surgery. Why did you choose this approach for this young patient?
Thank you. Thank you for your question. Excellent question. This video is for about 14 young males about the Otmir operation, because the parents about the patient is worried about the sexual function, because some case reports have said that some young males will lose their sexual function after the LVMI. So the parents ask us to do the perineal perineal operation. That's why we chose it. Thank you.
Thank you very much. That's good explanation.
Thank you.
Thank you. Okay, I think if there are not more questions from the group, we move on. And it's a pleasure for me to introduce Professor Dennis. She is from the Department of Gynecology at the University of Ulm, and she is the head of our pelvic floor center and an expert in treatment options of pelvic floor descendants from the gynecologic viewpoint, and we do several procedures together in patients. So please go ahead. Thank you very much that you could join our meeting, because she is basically attending another meeting in parallel in Freiburg.
Thank you very much, Marco, for the nice introduction. And dear colleagues and dear Congress Committee, it's a great pleasure to me to speak here today and give you some interdisciplinary insights in our work in the gynecology place. I will share my... Okay. So you can see my slides, I think. Yes, okay. So when we gynecologists, when we talk about pelvic organ prolapse, we normally have this vaginal view on the problems. So we have this bladder prolapse as a cyst or cell in the anterior compartment. We can have rectal prolapse. It's the anterior wall of the rectum, but the posterior wall of the vagina. And we also see often in combination with this rectal prolapse, this small bowel prolapse. And of course, we have this urethral prolapse in the distal way. Many patients with this kind of prolapse show symptoms of a stress urinary incontinence with leakage of urine during coughing or exercises. And patients with the uterine prolapse, you see here, the uterine is descendant to the hymen. And if many patients were hysterectomed before, so they can also show a vault prolapse of the vagina. Mostly we do ultrasound for diagnosis. As you can see here from the outside of the vagina, we place our abdominal scanner, and then we get these pictures. It's in analogy to the MRIs, but we keep it simple, and we always do this ultrasound. And you see here the symphysis, the bladder, urethra, vagina, and the anorectum. And I have the two pictures or two patients from I have seen in the last week. So this is the first one. We make this examination with our two instruments, and here you see the cervix, and when the patient is pushing, the cervix is coming down until the hymen. And when we replace the cervix, the patient is pressing again, and we see this defect in the anterior vaginal wall, which is not too big, and here is the posterior vaginal wall. And when we look at the corresponding ultrasound, here's the symphysis, here's the urethra, bladder, and we see this cervix coming down to the ultrasound. And the next patient, here's another patient. She had another problem in the examination. We see that the anterior wall is stable, but we get this great defect at the posterior vaginal wall with this small bowel at the vaginal fold. And we also see that in the ultrasound, corresponding ultrasound. This is urethra symphysis. She has no uterus anymore. And when she's pushing, You can see here the small bowel descending and the rectum is stable. So this is a small bowel as you had seen here in the examination. So, repair techniques. We began repairing the descendus prolapses from the vagina. So here you see the classical anterior repair of a cystocele. We open the vagina, we replace the cystocele and repairing the vaginal skin layer and also the connective tissues in between the vagina and the bladder, and corresponding on the posterior vaginal wall, we can also correct a small anterior descent of the rectum in the rectocele. But you also always only get this small part which we can reach from the vaginal way. For the descents of the uterus or the apex, we use mostly also vaginal techniques. And here you see our landmarks where we can fix the vagina. It's the ligamento-sacrospinosus ligament, or here, as you have seen at the colleague, and you also put the rectum here, the promontory with a laparoscopic, mostly robotic or abdominal approach. So our gold standard for the correction of an uterus descent in a patient's fit for laparoscopy, I show you this video. It's provided by my colleague here because I'm not sitting, I'm starting now with the robotics, and it's in threefold. So here we remove the uterus, but we leave the cervix because the cervix is quite a good tissue to fix the meshes afterwards. We have here the promontory, as you know it from your rectum fixations, and we open it with keeping the urethra and the nerves in mind. And here we open the posterior wall of the vagina and we try to go deep. And here again, it's the lateral wall of the peritoneum on the right side. We connect this. And here it's the anterior wall of the vagina. And in the same way, we open the tissue here. And mostly we place these meshes on the anterior and posterior wall and fix it at the cervix with non-resorbable sutures. And here you see the meshes. There are many kinds of meshes, but in Ulm we use also this one. This is another patient. The cervix here was removed. It's a second video. And here the apical part of the mesh is tacked, but we also can suture it. And then the peritoneum is closed, as you have seen that in the video from my colleague before, so that no mesh is seen in the abdomen. There are several other possibilities to remove place the meshes. As you can see here, you also can use the ligamentum pectineum at the lateral sides of the pelvis. It's an alternative when here vessels are at the front of the promontory or in really adipose patients. So this is another way to remove it, but it's not so good for stabilizing the anterior vaginal wall. And the third approach is that the arms of these meshes are thrown through or pulled through the peritoneum, and they are fixed in the abdominal wall. This is a really upcoming and popular operation method. It's called this Dubuisson procedure from France. And here you see vaginal correction. We also can place these measured from the vaginal root. It's mostly in patients with a recurrence of a descent of the bladder. And here we have the fixation in the apical part in this sacrospinosus ligament, and here in the arcus tendinous of the fascia pelvis on the right-hand side. And this is also a video. I had a webcam on my head, so it's not really stable. I hope you can see it. So first we place adrenaline in the anterior vaginal wall and we open it, and I have only a small sequence of this video to show you how to place the mesh. We have these instruments to place the sutures here in these landmarks, and afterwards the mesh is fixed on these sutures. So this is the apical part of the vaginal wall, and here is the distal part, and the mesh is placed in this layer in between bladder. This is the bladder, the serosa of the bladder, and the vagina. We don't use these meshes in the primary situation because in many countries these meshes are forbidden from the FDA warning, but in Europe we are still allowed to use them, and it's and here the suture is closed, and okay, so this is a small flow chart how we can decide to repair the prolapse. In gynecology, it's mostly depending on the anatomical dysfunction of the women, and in the most cases we make reconstructive repair, these obliterative repairs with closing the vagina in a kind of colpoclysis. It's only for really old patients with comorbidities. So mostly we try to reconstruct it, and for these vaginal apex defects, we mostly use our laparoscopic way with this use of meshes. And with the anterior vaginal wall or the posterior vaginal wall, we try to remove this additionally to these apex fixations with grafts by placing the mesh down to the pelvic floor. And if this is not necessary or not possible, we can use this vaginal route mostly in the first situation without meshes, and in the recurrence situation with mesh. Then it's often a discussion about uterine preservation or not. For the vaginal way, I prefer to preserve the uterus because I can use the cervix for placing the sutures and placing the uterus to the sacrospinous ligament. And for the laparoscopic approach, I prefer the supracervical hysterectomy so that I can place the mesh on the front and on the back of the vagina and to the cervix to remove it. So I thank you very much for your attention, and feel free to ask me some questions.
Miriam, thank you very much. for this wonderful presentation. It gives an insight, on a different viewpoint to the pelvic floor. We are more in the dorsal part, you're in the middle and front part. But I think, as we heard from the speakers before, it's often a combined problem and not only a single problem. So are there any questions?
Okay, can I ask you a question?
Yes.
So it's very nice talking about Professor Dennis, because she presented a very good technique from the view of gynecology. I think we have learned a lot much, So my question is, since you have used the meshes and especially trans-axis of vagina, so from the literature, maybe the mesh related complications like mesh erosion is the main problems. So do you have some cases had severe complications like this, and what's your attitude to dealing with such complications? You may give us some good advice, maybe. Thank you.
Yeah, thank you for this good question. That's the great discussion worldwide. So that's the reason why in the US and in Australia, the meshes are really restricted. Yes, we have these problems. I think these erosions are not so severe. Mostly they are small and you can remove them from the vaginal root. But I think that 10% of the patient get chronic pain because of these apical fixation at the sacrospinous ligament. This is near to the pudendal nerve and near to the sacral nerves. And sometimes there's too much tension on the mesh. And then these patients get pain and obstipation. And then you have to remove these apical arms of the meshes. And so I'm really restrictive with these vaginal meshes. We don't see these complications, or rather in the abdominal approach, but you have to be careful with the vaginal ones. And in Germany, we have this, you have to be a specialist to implant them. So normally you should be a pelvic floor center where you have many of these operations per year to have a surgeon's expertise.
Yeah, sure. Thank you very much. But what about the mesh itself? I know in Germany you have a very good mesh. It's a titanium coated. The problem, the mesh is something anti-adhesions, and also it's not so many shrinkage. I think it is. Do you have some experience or any data to tell us the titanium coated mesh?
Yes.
In your field, in Germany.
Yes, I for the vaginal root, this mesh I use is not titanium, and I have a good experience with that. And I only use the one because I think when you use several ones, you are not the specialist for the one. So for my procedures, I only use this mesh I showed you. So far as I know, there is by now no literature comparing these meshes. So for the apical fixation, we use this PVDF. It's not polypropylene. It's another kind of mesh, and it's thought to be a little bit better than polypropylene, but it's not clear. And I don't know if there are any studies to compare these kinds of meshes.
Okay, thank you. So thank you very much. Very good talking. Yeah.
Thank you.
Any more questions? Many thanks, Professor, and we should move.
Okay, so
Marco,
thank you very much, Miriam, and we move on. And it's my pleasure to introduce Artem Goncharov from Moscow, who will show us his experience about rectal prolapse with a double ventral mesh. Please go ahead.
Dear colleagues, thank you for your kind invitation. Thank you, Marco, Andrew. My topic today is the rectal prolapse in male patient and technique for treating the recurrent rectal prolapse. Rectal prolapse in male patient is such a rare disease and rare topic for the paper. In the PubMed, you can find only about 200 papers for many years. And if you focus on the studies, in the 70 years, described only 1,700 patients in 28 studies, and the term of recurrence is not clear. It can be up to 1/3 of all patients of all surgeries. If we look at the Dutch register, we can see that the about 1,600 patients for 10 years, and the male patients were only 5% of this group of this disease. We saw different types of surgeries, and the most common surgery is laparoscopic ventral mesh rectopexy in the last year. But we talk about full rectal prolapse. We have some patient with internal rectal interception, but we do not talk about the female with rictocele and so on. We saw today a lot of nice procedures of perineal approach, Altmaier procedure, Delorme procedure, but in my point of view, the Altmaier procedure, if the patient lives long, it have very big amount of recurrences, and maybe if you look at this patient after 3, 4, 5 years, 10 years, almost 100% of recurrences you will see. And it's the resection procedure with the anastomosis and with some problems with the pelvis inflammation. Today we hear about the other procedures, the Ripstein, Frickman, the Goldberry procedure. It's a rear posterior fixation of the rectum with the suture or with the mesh. And we talk about the very old data, and this data is that this procedures is followed to constipation and functional problem. But today we have the laparoscopy. I think that this procedures was all open, and we see nerves. We can do dissection in layers. And maybe it's not so clear that this rectal fixation, this rear fixation procedures are so bad. Maybe they are not so bad, but we have a few data on this. So here we see the amounts of the procedures, and in the beginning of 2004, 2005, a lot of perineal procedures, which in changes in the 2015. It's more than abdominal procedures, and it's most of them it's laparoscopic or robotic ventral mesh rectopexy. Underdoor is one of the author of this procedure. We're glad to have Wick in his hospital. And when I asked Andrew what to do with the male patients, he said, do the same procedure, laparoscopic ventral mesh rectopexy. And it's good in a female patient. You can fix all 3 layers of the rear compartment, and the dissection that was shown in the topic before today, we see the wide mobilization, wide dissection of the anterior rectum wall, a dissection through the pelvic floor, pelvic muscles, and fixate their a mesh. But what to do? And it works. It works. This procedure have release of obstructive defecation syndrome almost 86%, and low recurrences. You can use biologic mesh, non-biologic mesh, and have good results. But what to do in a male patient? Because we know that the wide dissection of the anterior wall of the rectum will cause the possible damage of the plexus, of the prostata, and so on, and can end with the patient with the sexual problem and with the problem with the urine. If we look at the beginning of the surgery, we find very interesting procedures like OR procedure. It's American surgeon published in 1946, or the suspension operation for rectal prolapse. They use the fascia from the leg and make 2 strips of the fascia on the anterior wall, not very far from the fixation, and this operation was good as for a female patient as for male patient. But here we see the 2 stripes of the fascia anteriorly. The other variant of this procedure is a Loge. Loge is a French surgeon. A lot of patients, low term of recurrence, male patient, and one of the features of this operation is the mobilizing the anterior and rear rectal wall, is shown on this picture from the paper, deep to the pelvis. And as we hear today, the only mobilization of this and fibrosis in these places can help to treat the prolapse, maybe without mesh. If we look at modern ways of the posterior rectopexy, we find this paper, posterior mobilization, fixation of the mesh to promontory, but other also made a point of view that the sac of the Douglas pouch is not resected in this procedure, and this may be a problem because it's a very very important part of the prolapse surgery. And maybe only suture rectopexy. Maybe we don't need meshes, and we see some cases, some series of this. It's very easy and fast procedure, but with a big recurrence after it. In this paper, we find that the posterior suture rectopexy have 23% of early recurrence. So we try to make a fusion with these techniques, procedures to achieve a good results in male patient, and we patented in Russian Federation this type of rectal prolapse surgery with using two meshes, anterior and posterior meshes. It's maybe looks like a gynecologist procedure, sacrocolpopexy, with using two meshes, but we make one step deeper and make fixation for the rectum, not for the vagina wall. Our experience for last years, my own experience is 48 patients with the rectal prolapse, and mostly we perform lab ventral mesh rectopexy or robotic ventral mesh rectopexy and some other perineal procedures. Most of patients were female and 7 patients was male. We preoperatively perform for every patient colonoscopy, physical examination. If we see full rectal prolapse with the 5-10 centimeters rectum outside, we do not perform defecography preoperatively, only perform after operation because we do not see a need for this. But in a patient with suspicious of the rectal interception, the defecography, we use two types of defecography, MRI defecography and X-ray fluoroscopy, because MRI defecography performed in the like in a bed position, it's not good for defecation, and fluoroscopy performing in the sitting position, it's better for patient to show the defecation. And in the patient with the full rectal prolapses, anal manometry and other procedures. We use 3 types of questionnaire: Wexner score, PFDI, pelvic floor distress inventory, and Russian Mitz-Rzhich scale. The first step of the procedure, we open the peritoneum and performing posterior dissection, avoiding the nerve damage. Laparoscopy or robotic surgery is very good to see nerves and to avoid nerve damage. We do not mobilize lateral sides of the rectum, only posterior sides. Left side is not mobilized at all. Right side is partly mobilized. We go down to the pelvic floor to see levator muscles, and then we start the anterior dissection. We use now this video monopolar hook, but last year we use mostly ultrasound, and it's not is main reason for this not to have electrocautery damage for the nerves, and we use the and we use in the end and we use the simple method for measure a mesh with the needle knot and cut, and we count three different measures for anterior and posterior wall. Then avoiding damage of the hypogastric nerve, we performing opening of the promontory, fixation with the posterior mesh with 2 sutures eti-bond 2-0 sutures on levator muscles, and then performing few PDS sutures for the mesorectal fascia and mesorectal on the posterior wall, leaving the long sutures to fixate them to let them fixate to the sacrum. Then we fixate anterior mesh. As you see, it's not far mobilization, and we do not mobilize the lateral ligaments, lateral parts, and fixate to the bowel wall only with PDS suture. We use semi-absorbable mesh, Ultra Pro, and fixate both meshes to the promontory with the stitches. We don't use the tackles. I don't like tackles, and I don't think that tackles is good enough for this. I think eti-bond suture is better. Usually we do 2 eti-bond suture, and it's enough, because we see the recurrence after tackles when tackles go off after the surgery. So we suture both limbs of the mesh. We widely use extracorporeal sutures. It makes this procedure easier and faster. And second stitch to the promontory. And after this, we close cul-de-sac, Douglas pouch, and this is the question: what to do with the Douglas sac? So now you see the robotic operation, robotic procedure in the female patient. It's performing in the same way. We will not focus on this. And we have 2 options: resect Douglas pouch, or to suture up with application of the Douglas pouch, as shown as the old surgeons do in their practice. We perform application suturing when we close the perineum. We stitch this deep Douglas pouch few times, and if we sometimes we use 2 or 3 this barbed suture to make good application of the Douglas pouch. So you can see the our data. We have observation time up to more than 40 months. We have a total 4 recurrence, and this recurrence looks like 3 recurrence in the 1 mesh group, only laparoscopic ventral mesh rectopexy, 1 recurrence in the 2 mesh group in the female patients, and male with 2 meshes, they have no recurrence. Functional results are very good and very optimistic, so we think that we can continue with this procedure, and we need to have more data to show the benefits or not benefits of this technique according to standard ventral mesh rectopexy. And here's the conclusion. We see good functional result, improved quality of life, low risk of recurrence, but we have small data, and its main problem that we can do a good trials. Thank you for your attention.
Artem, thank you very much for this interesting presentation and your videos. Are there any questions or comments?
Artem, what kind of contraindication do you see for this procedure and potential complication?
Contraindications. Thank you for good question. I don't see a contraindication for this procedure if a patient can fit abdominal procedure for 2-3 hours. And as a complication, we have in this group one complication, perforation of the diverticulum. I don't know, it's complication of procedure or it happens like this, and it was need to do a resection of the sigmoid.
My question is, when you fix your ventral mesh, you use the PDS or Prolene suture, and do you fix it directly to the rectal wall or also to the fascia?
Good question. Thank you. It depends of the type of mobilization. If we go and leave the fascia on the rectal wall, we fix it to the fascia. If we go a little bit deeper in the fat, closer to rectum wall, so we can suture to rectum walls. We perform few sutures on the rectal wall, not deep. We first procedures we always check from the rectum with the finger, not to make very deep suture. Afterward, we don't need. We only suture for muscle layer, and we used ethibond suture and PDS suture, but now we use only PDS suture for this part of operation. Ethibond suture we used only for the mesh and muscle or pelvic wall fixation.
Any more questions? Okay. Thank you very much for your excellent presentation, and we move forward. And next and last talk from Williams Surgery School from Professor Marko Korman. Please, Marko.
Yeah, thank you very much, Andrei, for your kind introduction. My talk is about treatment of rectal prolapse by robotic resection, rectopexy with dorsal mesh and transanal specimen evacuation. This is my introduction. I just show you a little bit about diagnostic workup, grading, surgical options, and then I will show you the robotic resection rectopexy, how we did almost 50 cases now. When we look at rectal prolapse in Germany, we have annually about 2,000 to 3,000 cases, so not very much. Our ratio in Germany is 9:1 female to male. We have early recurrence or when patients come around 20 to 30 years of age, and then we have the second peak of older patients, mainly female patients. And we have to deal with the internal rectal prolapse. Here, the main symptoms are how patients present pressure to the pelvic floor, incomplete evacuation of stool, and main problem of constipation. When you talk about the outer full thickness rectal prolapse, here pain, bleeding, and stool incontinence are the main symptoms. When we go through the diagnostic procedure of suspected internal prolapse, we do a proctologic examination, the specific history with the incontinence scores. We do a rectal digital examination, a proctorectoscopy, and we measure the anal pressure. My gold standard is MR defecography, because here you really can have a objective functional evaluation of problems of the pelvic floor. As Artem mentioned, the patient is not in the natural position of going to the toilet. So in addition, sometimes it's actually not bad to do a normal or conventional defecography. But we mainly rely on the MRI defecography. Then we do also colonoscopy that should not be older than 2 years. And of course, especially for the internal prolapse, we always go for consigliere examination by our gynecologists or urology and the pelvic floor center to detect patients that may take profit from a combined operation together with the gynecologists. Here are some findings. Miriam Dennis showed you these pictures already, what can happen or what kind of pelvic floor problems you can have. When we look at the rectal prolapse, we use the Oxford Prolapse grading system. You have a grade 1, grade 2, grade 3, 4, and 5 with the external full thickness prolapse. Here are some examples. What you can see, the enterocele, then full thickness outer prolapse. I mean, that is already clear from the clinic if you have an outer prolapse. So for outer prolapse, in my opinion, it's not really necessary to do an MRI defecography. We also heard about surgical treatment options in the talks before. You have the perineal transanal techniques, mucosa application, analraphy, the Delomer-Altmaier procedure, STAR and TransSTAR procedures. I have to admit I'm not a fan of these techniques because basically we can anesthesia, at least in our hands, is applicable also for ASA 3 or 4 patients. And then you can, if you go for a treatment, you can do a treatment also from the abdominal part. For the abdominal techniques, you have the rectopexy using suture, using mesh. You can place it posteriorly, anteriorly, combine it or use fascia. And what I prefer, because of most patients present with constipation, that you add to your rectopexy, you also go for a sigmoid resection. We talked about lowering of the pelvic floor. And I think, irrespective what we do, I think we have to, relieve the pressure from the pelvic floor and try to move it back to its original position. And we started to do these procedures several years ago using robotic surgery. You all know the advantages of robotic surgery. You can do a more precise layer-based anatomic preparation, especially in the pelvis. You have less blood loss, better preservation of neighboring organs and nerves, and probably also by using it, lower rates of complications and faster recovery. So I come to the procedure I would like to introduce or show you for discussion. We have the Da Vinci Xi system. We have 4 8mm Da Vinci trocars in the setup and 1 assistant trocar. And the steps of the operation are mobilization of the rectum and sigmoid. Then we go for the fixation of the mesh. We use the same as Artem showed you, the Ultra Pro partially absorbable mesh. We fix it at the promontorium and then we fix it at the rectal wall. We close the peritoneum and then we do a tubular sigmoid resection, do an evacuation of the specimen transanally, and we reconstruct the colon by using a hand-sewn intracorporeal 2-layer end-to-end anastomosis. Operation time is between 120 to 150 minutes. Hospital stay of patients about 4 to 6 days, and we at the moment have almost done 50 patients by this procedure. Here in the first video, I would show the cetus mobilization and the rectopexy. You see very long. This is a 36-year-old female patient. We did the operation in January 8th. So you mobilize open, and then we go in the PME layer down to the pelvic floor, as Artem also has shown you, and we mobilize it completely to the pelvic floor, incise the left peritoneum, and here you have the promontorium. You have to take care of the nerves. We place a mesh. We cut it a little bit like a butterfly. And also here really go in with the needle clearly to the bone. We fix the mesh. We do a second or third suture, also a bit lower at the sacrum. Here sometimes you can have, and then we fix the mesh. Or I also use the same sutures. I don't use I use the same sutures also for these fixations. We go through, and here I try to go to the rectal wall at the sides. So we do 2 sutures on the right side. And here, I try to fix it at the rectal wall. And now we go to the left side. Here you see a little bit, the border of the rectum. In contrast to the videos we have seen before, I do not open the front in these cases. So this is then the last fixation of the upper rectum on the left side. And you see now you already pull it up very nicely. And then we close completely the peritoneum. We rinse and make sure that you have no bleeding in the presacral space. And we close the peritoneum on the right side. On a regular basis, we do not put in any drainage. So this is the first step. You finish the rectopexy. And in the second part, same patient, we start mobilizing the sigma, and we do it about 5 to 6 centimeter above our mesh placement. We dissect it, staple it, close the distal sigma, and then we do a tubular sigmoid resection to the descending colon. We cut the descending colon, and now the specimen is loose. We do some helping sutures to help open the rectum. We open the distal sigma. And we remove the specimen. You see very long sigma. We remove this suture. And then we do a 2-layer end-to-end anastomosis. The upper part is still closed, so to minimize possible spillage. On a regular basis, we do a cleaning of the bowel before this operation. Like preparation for colonoscopy. So you have the first layer of the back wall is sutured. Then you open up the proximal part. You do the second layer of the full thickness using this barbed suture. For 0. So then we, with the same suture, we move to the front wall. We do a little, inversed suture of the front wall. I move here to the middle, then stop and start with another suture on the other side. And then the second row of the front wall is placed. Check if you have a good perfusion. We also use ICG on a regular basis. I did not include it in this video sequence. Yeah. And then finally we close also the perineum and the mesosigma completely. And this is the final situs at the end of the operation. You see the descendants is completely stretched out. So in summary, patients with rectal prolapse often present with a pelvic floor descensus in combination with an internal rectal prolapse. In my opinion, MRI defecography can dynamically give you an impression of the individual existing problems, because these patients often have more than one problem in the pelvic floor. And clear evidence, in my opinion, of the optimal surgical procedures do not exist. In Europe or Holland and also Germany, often ventral mesh rectopexy is performed. We prefer, depending on the symptoms of the patients, in case of grade 2 and 3, especially for grade 4 and definitely for grade 5 rectal prolapse, this minimal invasive abdominal dorsolateral mesh procedure. And in my opinion, and in my experience, as I have shown you here, this robotic resection rectopexy with transanal specimen evaluation is a very elegant, minimal invasive procedure. And I'm happy now to take questions or get comments. Thank you very much.
Thank you very much. Very nice, excellent procedure. Thank you. Looks very good. What about results and recurrence rate in your 50 patient?
I haven't shown you that. We had. I have to admit, at the moment we have a medical thesis running. The results are under evaluation. I have one patient. She had an anastomotic leakage, and we had to do a reoperation. That was a really bad case. She got a stoma. We had to remove the mesh and make a new anastomosis. We had a second patient. She had a little hematoma close to the mesh, and we had to do a CT guided drainage. These are the two cases. And I had one patient. I did a reoperation together with Miriam Denitz 2 weeks ago. I did this procedure 1 year ago. And the mesh was actually at the reoperation still in place, but despite this mesh, she had a complete prolapse of the vagina, of the bladder, and at the reoperation, I did again an L-shaped dorsal mesh of the rectum, and Miriam Denitz, she did a colposacropexy with a mesh to the vagina. So these are the 3 cases we had to do, or we had severe problems. Yeah, but these are just at the moment preliminary results. I just wanted to present this possible technique to you, and
Thank you.
Yeah, thank you, Professor Coleman. It's very perfect, and it's very new technique for the rectomy. I just want to ask one question: is how long should you cut the sigmoid colon? And depends what's the standard, and your with the mesh is the butterfly mesh. How to calculate what's the size and how long to cut these meshes? Thank you.
We use basically the mesh we use for Liechtenstein repair. It's a 6 to 12 centimeter partially resorbable mesh, and we cut it like a butterfly to about 6 centimeter long and about 8 centimeter wide. And that is placed. And sigma resection, I always remove the complete sigma, so you have a straight line from the left flexure coming down. And we do this resection on a regular basis. Because in my opinion, most of these patients really have a constipation. So after that, you get rid of this problem.
Okay, thank you.
Marco, may I have a question? Yeah,
of course.
Your lecture gave us a very deep impression. You used defecative MIR. I just wanted to know, is it need a special instrument or just a regular MIR?
To be honest, I I can't answer this question. I think it's our regular MRI. Yeah, but I have to ask our Department of Radiology. I don't know if it's a special MRI. Yeah, but they have a special gadget. When you fill the rectum inside and where you can do the defecation. Yeah, they are lying inside. They are not sitting. Yeah.
Lying, not sitting. Yeah,
No.
yeah, I understand.
Yeah.
Okay. For MRI, for rectal cancer, we staging. We need a special instrument for rectal cancer. So for defecation, imaging is much difficult, I think.
Yeah.
Thank you very much.
Marka, I have organization question. Could you describe the way of patient with pelvic floor problems in Germany? I mean, start of diagnostic before hospital, inside hospital, who responds for decision, and monitoring after hospital, long life, and feedback therapy and so on.
Could you please repeat? I didn't get it quite completely.
Okay. I would like to ask you about the way of patient with pelvic floor problems in Germany. I mean, before hospital, inside hospital, it's multidisciplinary team or who responds for decision. And actually, the most important question, who monitors patient after operation, long life, not inside hospital.
Most patients, they are not referred to the general surgeons here in Germany. You know, as they go to the pelvic floor centers, or because mainly are women, they are seen by the gynecologists. And I mean, we have to do a lot of work because the gynecologists often do not see the problem of the rectal prolapse. They focus on the front part of the pelvic floor, and so we have to sharpen the awareness. That's what I'm doing at the moment here in Germany. And so often patients are seen in the pelvic floor center by the gynecologists, and then meanwhile they send them to the proctologist, and we also do a examination of the rectum and of the back part of the pelvic floor. Some patients, but this is maybe 10% of our patients, they are seen by proctologists. They come with a full thickness external prolapse. I think then it's clear, and these patients are directly referred to general surgeons. So this is a way before, and of course, then you have to decide how to move on. Yeah, if you have a full thickness external prolapse, we don't need to go for all these diagnostic procedures. I think you can, in most of these patients, you can probably directly go for the surgical procedure. Yeah, one problem are young male patients, 20 to 30-year-olds. They mainly present with constipation, and people do not think about that they have a problem with pelvic floor descendants and, you know, very long sigma, and they are off. Some of these patients are sent to the psychological examination, and they say they don't have a problem. Nobody thinks about pelvic floor descendants in young male patients. So this is also a small group, but a group that severely can take benefit if you find the problem of these patients. Once you diagnosed it, I think then, you do the regular preoperative setup in the outpatient way, and patients come. In Germany at the moment, you know, we do the bowel decontamination. It's done. Patients do it at home. And then they come at the day of surgery to the hospital. You do the surgery. They are 3 to 5 days in the hospital. Of course, if you have the older and fragile patients, they prefer to stay a little bit longer. But usually you can dismiss them after 4 to 5 days. It should be no problem. And then the post-operative evaluation, we don't see them on a regular basis. We only see them again if they have problems. Yeah.
I see.
Did that answer your question?
I see. I understand. Professor Yunli?
Okay, so Yin Lu, did you have your hand is up? Do you have?
I already asked about MIR. I already asked.
Yeah.
Any more questions? Okay, it seems to me we can go to conclusion. And Professor Jai, can you ask a couple words?
Okay,
Just say a couple words.
Yeah, this afternoon, you know, the meeting is very interesting, so I'm so satisfied. Actually, it's a well-organized and highly standard web meetings, although we are small group talkings. So because we have 5 speakers from different kind of countries, East and West, it makes more internationally, I think. So about rectal prolapse is a common problem. I think it's also an old disorders, but we have many techniques to deal with. Mainly transperipheral or transventral. This is the main two to access. But with the development of the surgical modern technique like laparoscopic and robotics, and also the implantation of mesh innovations, I think it seems to be the more frequent operations is laparoscopic or robotic ventral mesh fixation of the prolapse. I think this is the internationally trends. But we cannot say which one is the best, but still we have a lot of questions to discussing. So I think 5 speakers give us a very knowledgeable information, and some of them, the data like in China, the Guangzhou, they have a very big case lot, more than 500 cases. And Westerns from Germany too, they use the modern technique, robotics, should have the talent technique. Also the Russian, they have their own experience. I think even India, So these are very good phenomena for the product in our society, I think. So the one of the things that we have to be focused is the mesh related complications, especially the erosion. I just mentioned about that. The more mesh is used, the more complications, more erosions. The erosions is one of the most serious complications about such in the techniques. So the surgeons should know to understand what is the advantages, what is the disadvantages of the meshes, and we have to parallelize. We have to compare which is suitable for what kind of operations. This is my advice. So finally, I would like to thank Dr. Andrei, Wolfs and your team to make such good web meetings, and also leading by Professor Marco Coleman. I think International Colorectal Cancer Club we are still developing and they're going on. So I hope maybe in the near future, maybe we have to organize the in-person meetings, not only on the website, the online, but also we can meet, we can discuss, we can make the surgery progress, we can make personal friendships, and we can make something changed. So this is my personal hope. So I thank you very much, all the speakers and participants. So thank you very much.
Thank you very much. Firstly of all, I would like to say thank you, Medical Academy from India, for invitation. Dr. Ray from Mumbai. Due to this, our club became wider to Asian, and actually we saw that unfortunately we don't have the gold standard for reach this difficult problem, and it seems to me mainly to notice what happened with patient before operation and after operation. It's very important to understand. Operation just a short moment in life of these patients. Many thanks all speakers for excellent presentation. And Yunli, please. We can't hear your microphone.
Yeah. Microphone open.
Yeah, sorry. In China, we afternoon, but in European, it's morning. Yeah, this afternoon, for me, is very interesting. I learned a lot from this meeting. From India, from Russia, from Germany. Actually, we're discussing about pelvic weakness problem. Unfortunately, tonight, this afternoon, we haven't gynecologist. Actually, different from the gynecologic and the rectal or general surgery. We have different between uterine and rectal prolapse. Actually, a lot of gynecologists know a knowledge about pelvic weak. Pelvic weak, maybe next time we can discuss combined with colorectal surgery and gynecologist. Now, thanks everybody contribution to this conference. I hope we can meet together face by face, face to face, just like Professor Ji wanted it. Thank you very much.
please, mark a final.
Yeah, I'm overwhelmed by this first year Zoom meeting. I have to admit, we had excellent presentations from Dr. Patankar from India, Professor Ren from Guangzhou. Miriam Dennis gave us a short viewpoint from the gynecology side, and Artem Goncharov showed us the Russian experience that actually is the same as I've shown you a little bit. We use the same mesh. I think the talk showed me that we facing the same problems all around, and we haven't found the best solution. I think, but what I learned, or what I more and more see, is that maybe we are not dealing with one disease, but rectal prolapse in its forms. I think we may have to differentiate it a little bit more and maybe individualize treatment, that we just do not one procedure, but really look in more and more detail, depending on mesh placement, no mesh placement, where to place it, if you have to do a sigmoid resection or not. So I hope by this meeting, we showed this for people who joined us today. And what we should do, maybe as a club, we should think about making a consensus paper. We have a lot of experts from all around the world, and maybe we should think about doing a review paper or consensus paper, putting together the thoughts and experiences from different countries or continents around the world. So these are my conclusions. At the end, I would deeply thank Andre. You again organized this Zoom meeting. You have all the staff in St. Petersburg, technicians who really helped to set up this meeting, that it's running without problems, and that we can record it and we can publish it on YouTube. So thank you very much, Andre. Yeah. And I hope we can maybe organize at the end of this year at some place around the world a meeting where we can come together and share our experiences. So thank you very much again. I think we should together think about maybe some next topics for a meeting in summer, and we can keep in contact and maybe work this out in the next few weeks. Yeah. So thank you very much, and to all countries that lie east of Germany, have a nice evening. We start the day here in Western Europe. And thank you very much for joining.
Many thanks.
Thank you. Yeah. Bye-bye, old friend and a new friend.
Bye-bye.